spoke to this group, I believe, some weeks ago, and I think gave me a pretty good start on how we see the work. What I'm here is to provide a perspective on care management as it's done by a not-for-profit entity that has a close relationship with caregivers, which has worked really well for us. We now have 72,000 members. About 30,000 of those are Medicare Advantage members, where we have 4.5 stars on the CMS rating system out of 5. We have about 42,000 military retirees and their dependents and dependents of active duty. And interestingly, we know that we care for in that population about 7,000 diabetics. We know who they are. We know where they stand in their illness. We know some things that we need to do for them to improve their condition. We have about 3,000 people with congestive heart failure in our population for whom we provide care. And we really believe deeply in the concept of clinically managed care. We believe that this yields two things. On one hand, it yields lower costs, but also we're completely convinced, having been in this work for many years now, that it also is very good, has very good outcomes for beneficiaries and better healthcare experience. We, as you probably would recognize, have to manage the very actively ill, those people that are in the care system through their transitions, to try to get them a home and not back into the care system. We have a very good system for identifying risks, and I think the plans with which you do business, you would want to know where your high-risk people, the people who are likely to wind up having to go into the hospital or to have other care. People like the patients with congestive heart failure. In our population of 3,000, about 500 of them are now in a program where they have visiting nurse visits once or twice weekly, be weighed to check their pills, make sure that they're doing well, and that has significantly reduced their admissions. Or for those that are potentially going to be ill in the future. And we're really working to close a lot of gaps in care around the needs of those people with diabetes. As I think about it, I think of my friends at Kaiser of Southern California who have 171,000 diabetic patients, most of whom now they have on a 3-drug regimen that reduces their likelihood of heart attacks, strokes, or amputations by about 50%. So we are active advocates for clinically managed care entity, and really interested in advocating that should Medicaid and MaineCare be expanded, that it be done with a managed model.
Thank you very much, Dr. Hess.
Are there questions from the committee? We have Representative Starkey and Representative Bonvicki.
Thank you, Madam Chair. Thank you, Doctor. I have a question about Medicare Advantage. How is that affecting youth in the managed care system? My mother's on a Medicare Advantage plan and she was just dumped. So I just am curious to know how that's affecting Martin's point. And
I'm not sure that we began our Medicare Advantage plan a number of years ago, actually began in 2008. It has for us, it has been enormously gratifying work because it allows us to assume the responsibility and accountability for those populations who we're providing care. We have not and do not ever intend to dump our Medicare Advantage members. We have a number of people in our plan who are sick and have been very sick for many years, and our goal and intention is to see that they get really well cared for.
how do you absorb how are implemented?
You're speaking about something that's really interesting. The Medicare Advantage program has had a sequence of reductions in payment, and according to the advance notice that we received this week, we'll probably see another 1 or 2% reduction reduction. What each of those has done is to force us to redouble our efforts to understand who's at risk and how do we reach out to them in ways that help us to reduce admissions, reduce readmissions, improve transitions of care, to try to improve the health of the population in ways that reduces their total cost of care, while at the same time serving them well.
I'm going to directly for following Senator Dean, because I wanted to just have a follow-up for that from Senator Starkey, Representative Starkey. Are there built-in, laws that would protect, or patient protections, where a managed care organization would not be allowed to refuse a coverage or service for an individual, or if they were in the plan, to be discharged from the plan?
Yes, as far as I know, I'm not really certain what Representative Strachey's family story is, but we are essentially required to accept for membership in our plan anyone who is qualified based on the fact that they are Medicare eligible. And we are not allowed to discharge anyone from the plan as long as they have paid. In our case, most of our plans are very low premium or no premium, but if they fail to pay premium, we're allowed to discharge them. But not for clinical events, risk, cost. Those are really assumed to be the responsibility of the plan.
Apologize, Representative.
Thank you, Doctor. Senator, you heard Senator Katz describe the bill and the things that are here. I don't know if you've had a chance to really look at it that carefully. But again, based on what you heard, knowing there's a stakeholder process that's going to happen and issuance of RPs, based on what you heard, does it sound, in your opinion, that we're going down the right road in developing something that an entity like Martin's Point might be interested in participating? And I think it's important to the Senator and to some of us in the room, as we talk this through, that we create something that is, that is attractive and possible to not-for-profit entities who are locally based and participated in this.
Well, I think what I would say is, I'm not going to. We would absolutely respond to a request for information, but I want it to be clear that I'm not here as part of an advocacy effort for Martin's Point. As I listened to what Senator Katz's bill included, it felt complete and it felt reasonable. I feel very positively there are good consumer protections that are being talked about here. There are good quality measures that are being talked about here, and there's a solid competitive process for the selection of plans. As I look at it, I think this bill makes sense, but I have not read every word of it, and I would not be able to comment on it comprehensively.
Okay, thank you. That was very helpful.
Representative Manley.
Thank you, Madam Chair, and thank you, Doctor. Doctor, given, as you just stated, you're not here as an advocate on behalf of Martin's Point, but I feel like my question is a little loaded, so please accept what I'm about to say or the query I'm about to make. How would your organization's life and structure be different were you to be reimbursed at the current Medicaid main reimbursement rates as opposed to your Medicare Advantage rates?
I think what I would tell you is that if you look at a medical group today that accepts medical group payments, you really are receiving payments for a fraction of the total care that is offered to a patient beneficiary. The work of a health plan or a Medicare or Medicaid program is really very different. That plan is responsible for a whole set of administrative functions to start with, and those include enrollment, They include member outreach. They include claims payment. They include what we call our health management department, which Ellen runs for us. And it requires an information infrastructure in which you understand all of the people for whom you're responsible in your plan, and you know and understand their illnesses and risks, and that you are building programs for those individuals that will help to reduce those risks, improve their health, and ultimately reduce the total cost of care. If you are simply caring for individuals, to cycle back to a practice view, you really are only responsible for a very narrow slice of what they do. Very different functionalities, and we actually do both, but they're very different.
Representative Dorney and then Representative Cassidy.
Thanks, Madam Chair. I have a couple questions. So I'm assuming that each of these companies that would bid and maybe get the contract would have different formularies, is that correct? That would be your assumption?
That's great, Senator Katz.
Well, let me assume my ignorance by asking, you're talking about drug formularies?
Correct.
Yeah, the specific formulary protocol, as I understand it, is designed to be established in the rulemaking following stakeholder group input. I don't think there's anything terribly specific in here on that because of that.
So that would have to still be determined. There could be one formula for all these groups, or it could be that each company makes their own formula. We don't know the answer.
No, I know so very little about it that I really don't want to venture into it, but it would seem to me that the more likely result is they would all have the same formulary, because we're looking for uniformity statewide with these companies, but I don't know for sure.
Okay, and then who decides payments to doctors and hospitals? And that's decided by the company? And
No,
then
that's
they can negotiate.
And I think that's a real. Thank you for the question. I think that's an important point in this bill. Currently, the rates, as I understand it, are set by the department. We kind of starve the department, and the rates get set. But these rates are the product of negotiation between the department and the managed care organizations. And one of the, I think, important reasons to have 3 or 4 companies as opposed to one is it gives the department more leverage and a better bargaining position in negotiating that rate. For instance, if you only have one provider, which would be a lousy idea, state doesn't really have all that much leverage in negotiating rates, because if the provider won't do it, there's no coverage for people. But here, with 3 or 4 providers, it would be the product of negotiation. I'd like to assume that results in a better deal for providers than we necessarily have when they're dealing just directly with the rates set by the department.
I think my understanding looking at this, what I've read, is that the negotiation is between the department and the company.
Yeah, I'm sorry.
That's different. That's not the question I'm asking.
I'm sorry.
Which is, how do doctors and hospitals get paid?
The same
so
way.
They would get paid, I would assume, from the companies that have the managed care product.
Correct.
And does the department have any say over that, or the doctors can decide if they want to take patients from the first plan but not the second plan, so half of their Medicaid patients actually you can't take care of anymore? I'm just trying to get a sense of.
Again, I'll defer some of this to the stakeholder process, but the way this is written, the rates between the managed care organization and the providers will be negotiated between the managed care organization and the providers. Again, keep in mind that all 3 or 4 of them would have to have a statewide presence, and unless they have a rich network set up statewide, they won't qualify for acceptance by the department as being one of the providers.
So basically, a doctor's office could say, I'll take patients, I'm willing to negotiate this price for 3 of the 4 providers, but not the 4th provider.
I think that's a result. If that's a bad result, it seems to me that could be addressed through the stakeholder process. But perhaps
I think that it is true that, by and large, most groups do deal with all plans, but there may be circumstances in which a group would not be able to negotiate a rate with a plan. And in that case, you're right, that you would have some caregivers provide physicians and hospitals who might conceivably not be open to all Medicaid patients.
And on page 3, it has medical loss ratio of at least 85%. Does that mean administrative costs has to be 15% or less? I'm not sure what medical loss ratio means.
It does, and I think that's intended to be consistent with the language that applies to private companies. And go back to your last point, Doctor, if I could. I just want to point out on the next page in section 3, and here it's talking about the access to a provider network for members. It says the access standards must ensure access to care for both adult members and child members that it is equal or greater than available access to care that non-members have in the same geographic area. So that's, I think, trying to get to the point you were raising about making sure that there is a choice of providers out there for members. And as I understand it, for instance, someone who's on MaineCare and Augusta would have to have about the same kind of access to a variety of practices that I do as a member of the state healthcare system.
I have one more question that has to do with, I don't know what page it is. It's section A, number 8, MaineCare benefits under managed care plans. It talks about a managed care plan must cover all services and benefits required as of April 1st, 2014. I'm just thinking about, we currently have state law that says that MaineCare only has to pay for Suboxone and Methadone for 2 years. Right now we have a process through MaineCare where we have a prioritization system. And for certain categories of people, usually they will approve, for instance, Suboxone treatment. But I'm assuming, since this says that only things that are required by law, that they actually could just say 2 years is up, and even if they're pregnant or even if they're mentally ill, they wouldn't have to provide that coverage. Is that correct?
I don't know. I hadn't thought of that. But again, I would hope that that's a detail that could be addressed through rulemaking that exists.
Representative Katz.
Thank you, Madam Chair, and it's a question for Senator Katz. Under this bill, what are some of the expectations and likely changes ahead for Maine FQHCs, the federally qualified health centers, as providers?
Well, I think if you take a look at the bill, and I can't put my finger on the exact section, there are built-in provisions in this that require inclusion of those providers in any managed care organization's access network. So the intent of the law, and I think it's clearly stated, if I didn't point out to you exactly, is that the FQHCs, the value of the work they do is not going to be in any way negatively affected by the imposition of managed care.
Thank you.
Representative Sanderson.
Thank you, Madam Chair. This is Dr. House. How many people do you currently have in your main plan now? And I know it's not the Medicaid population.
I would say we have 30,000 Medicare Advantage members, or 28.6, I believe it is right now. And then we have, in our military retiree plan, we have about 30,000.
Now, you were saying there's going to be a tremendous amount of work on the front end that you're going to have to do before you would be prepared to, should this law pass, and should you be a successful bidder under the RFP process for this, administrative functions, the outreach piece, eligibility piece, having your system be able to work in conjunction with MaineCare systems, etc. How much of that stuff is already in place, and how long after you're awarded the RFP process would it take to get that up and running?
I can tell you that when we've never done this before. We've not been in this work, and I want to be clear about that. But what I will tell you is that when I have been associated with organizations that have done it, it has taken about a year from beginning to end.
Once the RFP, once you know that you have secured the contract. Okay, 1 year after securing contract. Okay.
It can be accelerated, and some plans, were Maine were Maine to select a plan who is from out of state and who is already set up to do Medicaid, a lot of what they do is pretty standardized. Some is not, but a lot is. And for an organization of that sort, it probably could be considerably shorter.
Okay. But that would be if we were to have entities who have it up and running.
Yeah, I'll give you an example. In Massachusetts, there's a very fine not-for-profit Medicaid managed care entity called Neighborhood Health Plan. There's another one that's called a Network Health. Both of those are not-for-profit entities. Both of them care for large numbers of quite frail and vulnerable Medicaid beneficiaries, and both of them have been set up explicitly for the purpose of providing Medicaid managed care.
Thank you.
Other questions for Senator Katz or Dr. House?
Maybe for both of you, you see this as phasing in the different populations?
Thank you, Representative. I can tell you the answer to that is yes, and if you take a look at, again, I think that there's a may that should be changed to a must, but in Section 2, it talks about phasing these populations in over a period of years, and it was anticipated that the stakeholder group would probably come up with 3 years, which seems like a reasonable period of time, starting with the easier and going to the more difficult, but a 3-year phase-in period for managed care enrollment.
And for Dr. House, I would like to explore a little bit about the experience in terms of working with people with intellectual and developmental disabilities. It's a very different kind of an issue because it's not like you treat them and they get well.
No.
You're talking about a condition as opposed to an illness or that sort of thing. Have you had that kind of an experience, or what experience are you aware of with managed care companies that have worked with this particular population?
I would tell you that we have not had this experience, and it's a capability that were we to be a bidder, we would have to develop. I have a lot of familiarity with Medicaid managed care plans who do this work. It's very labor intensive. A great example is the Fallon Health Plan in Massachusetts, where they do a lot of work for the at-risk, disabled community. Another really well-respected plan is in Minneapolis called MaineCare, founded by the University of Minnesota Medical School, where they have a very large Medicaid/Medicare special needs plan, where all of the Medicare and their Medicaid funds are bundled, and they integrate the two kinds of care into a single operating process.
I'm the chair. I can ask. So it would seem to me that people with intellectual disabilities and seniors or people who qualify for Medicare have really